Okay, welcome to everyone who's joining us online. If you haven't gotten the message, Tegrity is being shut down, so we're migrating to a new system. We'll put out email with all the directions for logging into the new system, and the recorded lectures will be available both in the new system and also on YouTube. Okay, so continuing our lymphoid extravaganza. Shane, what do you see here?
I see nodular and diffuse, kind of intermediate size cells. It looks like more in the B-cell chapter, but there's like the smudge there as well, which you said is new. Some of the cells are large.
Yeah, but the nuclei isn't huge. There's a lot of cytoplasm, and there's a little bit of a paranuclear hop. See that little crescentic pale area there? So how would you describe a cell with an eccentric nucleus and a paranuclear hop?
That would be a plasma.
Or a plasmacytoid. I mean, they don't have the clock-faced nuclei of benign plasma cells, but they're plasmacytoid. So tell me about, give me at least two possibilities for plasmacytoid Bs.
You have the one that's associated with the Borrelia exposure.
Okay, and what does that patient look like?
I'm not sure.
He's a 70-plus-year-old German man. Okay. So he's not American, so he's not like a German who grew up in Wisconsin. He's like a German because the Borrelia we have in the States doesn't tend to do that, right? That's Afzelii, which doesn't give you advanced Lyme, doesn't give you neuro-Lyme and things like that because you're lymphoproliferative. So he's an old German man with a tense pink nodule on his ankle. And it's sheets of plasmacytoid Bs with Dutcher bodies, which are like intranuclear pink immunoglobulin inclusions. Sort of like a Russell body, except that it's intranuclear. And then you can have what's the nastier end of the spectrum of plasmacytoid things.
So like the marginal zone lymphoma has progressed.
So
to kind of appear that way.
Or in the plasma cell world, more like myeloma, like far end plasma cell. Any markers that may not work reliably in something that has plasma cell differentiation?
CD20.
Like CD20. So what might you reach for instead of CD20? What stains earlier in B life and later?
79A.
You got it,
Right.
79A. Okay. So remember, pitfalls of 20 are anyone who's been treated with rituximab and relapses. They relapse because they lose 20. They lose the target. And 79A picks up pre-B cells and plasma cells, whereas CD20 doesn't reliably pick up either. Okay, well done. All right, there we go.
So, see kind of a predominantly nodular pattern.
Okay, and if you were to look at the normal components of a lymph node, where you'd have a germinal center and you'd have a round mantle zone around it with an inconspicuous gray marginal zone between the germinal center and the mantle zone, compare that to what you're seeing here.
I think you have, could you say you have like loss of clarity a little bit?
So,
Like an attenuated surroundings, maybe.
well, you certainly have attenuated surroundings, right? So the little bits of mantle zone that are left is not much, right? And it's discontinuous. How about the shape? A germinal center, what's the shape of a normal germinal center?
Round.
Round. Is what we're looking at round?
Down.
No, I mean, I'm not even sure what that is. That's some kind of monster with 2 arms and a weird body, right? Look at all of these. They are weird shapes for germinal centers, right? So they have discontinuous partial mantle zones. There's no polarity in staining. And they are weird shapes. So what population do you think is malignant here? Do you think it's the mantle zone, the marginal zone, the follicle center?
I mean, I think I would be concerned about like a follicle center.
Follicle center, because you have weird shaped follicle centers, and it's crushed and replaced everything else, right? So this one is not diffuse. It still is in follicles, right? So how would you expect it to stain?
So I would expect it to be CD10 positive, BCL6 positive. 2 would mean if it's primary nodal and it goes to the skin.
Or 20% of primary cutaneous. So it's 80-20.
Right.
80% of primary cutaneous are negative for BCL2, but 20% are positive for BCL2.
And then 20.
So if it's BCL2 positive, you work them up for systemic lymphoma, but you work them all up for systemic. You stage everyone. So, okay, what if it were more diffuse? What would you expect it to lose first?
CD10.
Correct. But it tends to keep BCL6. So that's pretty much it. It's not a whole lot more complicated than that. So when you look at it, it's which population looks weird, which one isn't doing what it's supposed to be doing, which one is replacing being bossy and pushing the others out of the way, and then look to see, do your markers match what you'd predict it to match.
I got a lot of cells here.
Got a lot of cells, and
Not really good.
are they pale or darker?
Very dark. They're not really organized into
And
follicles very well.
they're not organized into follicles. In fact, what you have left of a follicle center is kind of squished.
Mm-hmm.
So do you think it's the follicle center population that's expanded, or something peripheral to the follicle center that
Peripheral
expanded?
to the regional manager.
And you have, it's hard to tell because this is a punch biopsy, but there's maybe a little bit of vertical orientation to the infiltrate. So, what's the differential? What things could it be?
So like a marginal zone.
Yeah, marginal zone, common things being common, or mantle zone if you're reaching for much less common things in skin. So how would you expect a marginal zone lymphoma to stain?
BCL2 and 20 and 79.
And 20 and 79. How about BCL6 and CD10?
Usually not BCL6.
Only to the squash germinal centers.
Right.
Well, and if you look at your BCL2 cells, you'll see them infiltrating that germinal center. In fact, when you look at this germinal centers are usually pale, right, with larger cells. See all these dark cells that look just like the lymphoma on the outside that are percolating into that germinal center?
Mm-hmm.
So in a follicle center lymphoma, the nasty goldfish in the follicle center don't stay in their bowl, they jump out. And in a marginal zone lymphoma, the nasty cells don't stay at the periphery, they jump inward and invade inward. So, So you'd stain it to see, is that really a follicle center or remnant? And the best way to tell that is to do CD21 or CD23, see if there's a little net left there saying that was a follicle center, and then you see all of those cells that don't belong in the center that have invaded the center, and the staining would help. Any way of establishing clonality short of PCR?
I mean, like, you're not talking about like the where you look at the light chain restriction.
Yeah, that's exactly.
Okay.
So, and you get extra credit for phrasing it as Jeopardy in the form of a
I'm
question.
sitting next to Robbie.
Okay, so that's absolutely right. So for which lymphomas does light chain restriction really work well on tissue? Which ones is it really helpful? Anyone? Pretty much marginal. That's about it. It doesn't really work well in any of the others, but marginal zone, and what cells are you looking for? Is it all these lymphs? What are you looking for that show light chain restriction? It's the plasma cells at the periphery. And so for years, people tried to do it and saying, well, we can't get these cells to stain for anything. And they were just ignoring that little population of plasma cells at the periphery that had a 10-fold aberration in what it was supposed to have. So it's those few little plasma cells at the periphery that you look at. What's normal capital lambda? 2 to 1. 2 to 1 capital lambda. So to have a 10-fold aberration, if it's kappa light chain restriction, it has to be 20 to 1. If it's lambda light chain restriction, it only has to be 5 to 1, because that's a 10-fold aberration from normal, which is 2 to 1. Okay, so if it's kappa predominant, you have to be at 20 to 1 for it to count as a 10-fold aberration. If it's lambda predominant, it only has to be 5 to 1, because normal is 2 kappas to every lambda. And it didn't work very well when we did it by immunohistochemistry. It works great if you do it by in situ hybridization. So pretty much every lab does in situ for Epstein-Barr virus, and in situ for HPV types, and in situ for kappa and lambda restriction. Those are kind of the reasons you keep chromogenic in situ CISH around. In terms of PCR studies, everyone does PCR because it's cheap and it's easy. It's also much less sensitive than when we used to do it by southern blotting. So you'll have a fair number of false negatives and false positives that didn't exist back in the days, or were less of a problem back in the days of southern blotting. So PCR is cheap, it's easy. Problem is, it's not as good a test as southern blotting was. And so, it's fraught with some problems. And when you look at data in terms of how good PCR is, you have to compare it to, you have to look at what the technique was that was used. Okay.
Diffuse pattern here.
So you got a diffuse pattern, and it goes all the way up to the surface, right? So sheets of these cells, and if you look at the cells, what's their predominant morphology? Cleaved or non-cleaved?
I think they're non-cleaved.
Non-cleaved. Non-cleaved with prominent nucleoli. Now this nucleolus is at the center, so what do you call that kind of cell?
The center.
Or, I'm sorry, it's at the periphery,
Yeah,
sorry.
that's a centroblast.
So that's a centroblast, and when the nucleus is central, it's immunoblast. But basically what you're seeing, like this down here, is an immunoblast. Let's see if we can, like that's an immunoblast. That's a beautiful immunoblast off the field for some people online. Like that's the world's perfect immunoblast. Why are we not? Because it's still. Oh, you know what? We are. Okay. There it is. We finally got it onto the screen. Where is our guy here? Okay, there's our pointer. I don't know why we're so off. Okay, right there. With the nucleus in the center, and then a centroblast would be like this guy here, which is again a round nucleus, but the nucleolus off to the side. So these are sheets of blasts. What kind of blastic lymphomas do you know of in skin? What if I'm a 95-year-old woman with an ulcer on my leg? So that'd be leg type, which is a blastic follicle center type of lymphoma. So it's a follicle center lymphoma that's become diffuse, so it loses CD10. It's become blastic, so it usually even loses BCL6. It's picked up BCL2, and it's picked up MUM1. And it has a much worse prognosis. So that would be leg-type lymphoma. Other blastic things we see, there are other primitive blastic lymphomas, and the blastic plasmacytoid dendritic is really leukemia rather than lymphoma. Those are blastic tumors we see in skin.
So follicle center is plastic, if you select B cell, the subtype of follicle center, is it?
So there are lymphomas that are systemic lymphomas that appear in skin, and a lot of those are large Bs. And then there are the ones that were primary in skin. Of the ones that were primary in skin, follicular type of follicle center lymphoma is the best differentiated, and it keeps almost all of its markers. Diffuse type is a little less well differentiated and loses some of its markers, especially CD10. Leg type is a nasty blastic activated version that has lost even more of its markers and picked up some aberrant markers like MUM1 and BCL2. And with each step to less differentiated, you would think prognosis is worse, but prognosis for follicular and diffuse primary are the same. It's not until it gets to blastic that you have a step off and it becomes significantly worse. So for most lymphomas, you would expect follicular to be better differentiated and have a better prognosis, but for primary cutaneous, a diffuse follicle center lymphoma and a follicular follicle center lymphoma have the same good prognosis. Not as good as marginal zone, but still relatively good. Okay. So
there are germinal centers here. I actually can see. And it looks like it's the follicle center that's getting a little bit larger.
So it looks like follicle center that in some cases is too large, too big. Is it round?
It's like not perfectly round. They're kind of like distorted little circles and not suppressants.
Is there an intact mantle zone all the way around it, or has it pushed it out of the way?
It's pushed out of the way in a lot of them.
Okay, so you'd expect that this is probably a follicle center lymphoma. And how would you expect it to stain?
BCL6 negative, BCL2 positive.
Oh, I'm sorry.
BCL2 positive, BCL6 negative, and like the B cell markers, and then CD10 positive.
Okay, CD10 positive. You got your 6 and your 2
Did I miss
reversed, yeah.
2 is in mantle or marginal, and 6 is in follicle.
You got it.
Sorry.
Yeah. And one way to remember it, follicle F, what letter of the alphabet is it? 6. Right? So if you get messed up, F is the 6th letter of the alphabet, so it helps you remember BCL6 goes with follicle center. Okay. Okay, very good. So we're also looking at sort of prototypical cases. Just when you think you have it all figured out, then you look at a real one. And they're, people who've practiced Dermpath for 35 years, what sessions do they attend at the annual meeting? The lymphoid ones and the melanocytic ones, because they're still the ones you want to get a little better every year. Okay. How about this guy?
Like a nodular, like multifocal nodular pattern.
Okay.
Almost perivascular or periadnexal, perhaps.
Yeah, sort of perivascular, periadnexal. If you had to say some of them that are oblong in configuration, are they more vertically or more horizontally oriented?
There's definitely some vertical.
Yeah, there's definitely some vertical orientation. And if you had to say it's pale, jet black, or gray, where would it fall in there?
Gray.
Yeah, pretty much gray. It's not as pale. The germinal center, follicle center lymphomas, those are pale lymphomas, right? And mantle zone, when you see it, that's a jet black lymphoma. Marginal zones tend to be gray and vertical, with medium-sized cells. They're not as big as germinal center cells. So medium-sized cells that are often a little cleaved, so they've been described confusingly as like small centrocytes, but it has nothing to do with a centrocyte, which is a germinal center cell. It just means they can be a little cleaved, right? It's better some of the cytologic descriptions become confusing when they use a follicle center description to describe a cell that's not follicle center. So it's best to think of it, at scan as gray, vertically oriented, perivascular, periadnexal. And then how would you expect it to stain?
So marginal, so it's going to be BCL2 positive. I guess this one would probably be CD10 positive and CD20.
So
No.
CD20 positive, how about
Not
CD10?
CD10 negative.
So what might you see in CD10 is you might see some little crushed residual follicle centers somewhere. Those are perfectly benign. They're just having a bad day because this angry crowd is squashing them from all sides. And you could look with, like in this one, I don't really make out any follicle center, right? But if you do a CD21 or a CD23, you could make out little bits of network left where your follicle centers used to be and just got totally replaced. The other way to look at this is I have a big heavy lymphoid infiltrate in the eccrine coil. Tell me some things that do that.
So your L's, Louis, lymphoma, lupus, and lichen striatus.
That's pretty much it. Lupus, lymphoma, lichen striatus, Louis are all things that can do that.
So this one's predominantly nodular, at least in this little triangle. They seem to be larger cells.
Yeah, kind of larger. If you go back to your 3-point scale of pale gray or jet black,
They're definitely not jet black.
and they're definitely not jet black, so they're somewhere between pale and gray, right? In terms of size, do they look like the marginal zone or more like follicle center?
I think more like follicle center.
Yeah, probably more like follicle center. And then, so you're starting to form your opinion on H&E, and then you got to see, are your markers making sense, right? So you'd want to look and see with a CD21 or CD23, do you have a follicular dendritic network? you'd expect that this would be something that's outgrown its follicular dendritic network and punched holes in it. We don't see a really good mantle zone or marginal zone around it. Maybe a little wimpy one off to the side here. Should I spend a lot of money on in situ hybridization for kappa and lambda on this?
I don't think so.
Why?
Very poor sensitivity.
Yeah, because that's mainly good in what?
The
Which one is it helpful for?
marginal?
Marginal. Correct.
Okay, so I'm just taking like a step back.
Yeah.
If I got that, like we probably won't have like that as a slide in our exam, but if we did, and I didn't know like we were in lymphoma chapters, those cells look so like large and irregular to me. How are you going about making that like lymphoma versus some sort of other
Okay.
very
So,
large bad malignancy?
um,
Because like in my mind, I look at it and like especially when you're like it's malignant looking. You know?
okay. So, not to focus too much on exam, but
Or life.
if you, yeah, so in life, if you were going to look at that, can you make the diagnosis without lots of ancillary information?
Okay.
So, becomes very difficult to make a straightforward question, right? You could ask specific questions about it, but what's the diagnosis is kind of hard when you
Just
need
making
lots
sure
of
that I
ancillary
understand
studies.
That's where we are.
Yeah.
Okay.
The exam reflects your scope of practice, and things aren't supposed to be tricky, and it's supposed to be an assessment of your actual competence to practice as close as that can be done in an exam. So
if I'm getting like those are malignant cells that like that's okay.
well, in real life, what are you going to do? You're going to biopsy something, rule out basal cell, and you're going to see that infiltrate. What are you going to do? Are you going to blithely sign that out as not BCC next case, or you're going to refer it?
Yeah.
Right? Derms, by virtue of your certification, you are certified to sign out basic derm path, just like any general pathologist is certified to sign out basic derm path. Your credentials are equivalent to that of a graduated dermatologist in terms of signing out skin specimens. Both a general pathologist and a general dermatologist should know their limits and know, what they should sign out and what they should refer if they're signing out. And there are general path people who don't sign out a lot of skin, but probably all of them sign out at least some skin. And there are derms who don't necessarily sign out a lot of skin, but if you do Mohs, you're signing out skin, right? And if you do Mohs, you're going to run into lymphomas, especially which one are you most likely to run into if you are doing Mohs? CLL, those big lymphoid aggregates that just don't go away, and when you stain them, they're CD20 positive, whereas most reactive things in skin are T cell. Okay, so it's know what's common, what's likely to get you into trouble in practice, where your pitfalls are. Okay, how are we doing here?
So more superficial dermal infiltrate. See a ton of epidermal tropism. Maybe a
Correct.
little
So
bit
you
there.
don't. And so there are a few lymphs in the epidermis. How do you tell if it's exocytosis, which is benign, or epidermotropism, which is malignant?
Is there associated spongiosis?
So associated spongiosis. So in this case, is there associated spongiosis?
A little bit, yes.
Yeah, I'd say plenty, right? And then you look at where are the nasties? Where are the nasty cells? So if you look at these cells down perivascular and these cells up in the epidermis, which are the big ugly ones? The ones in the epidermis or the ones down below?
Down below.
Yeah. Whereas in MF it would be the reverse, right? So in T-cell lymphomas, your big ugly nasties tend to be up in the epidermis, in a B lymphoma, can you have a little associated spongiosis and exocytosis? Sure you can. How do you tell how much spongiosis in proportion to the limbs, and where are the ugly lymphs? Okay, in this case, the ugly lymphs are down perivascular, not in the epidermis. All right, so we've got all of these ugliform cells here. So we've got ugliform cells and their mitotic figures, and when you look at them, based on the morphology of these cells, tell me what kind of stains you want.
So CD20 to rule out like a B cell.
So CD20 is fine to rule out a B.
Maybe CD30.
Maybe CD30. Why are you saying CD30?
It kind of looks like a Reed Sternberg cell.
They look kind of Reed Sternberg-y. So these are all CD30 positive. And they're in sheets and clusters and perivascular rosettes.
Anaplastic large cell.
So ALCL, but the patient has little evanescent crops of papules that become necrotic and go away.
So LYP.
Yeah. So remember that there's a reason we sign out things as CD30 positive lymphoproliferative disorder, because without the clinical, you don't know how it's going to behave, right? And the big question is this systemic ALCL, which doesn't behave very nicely. If it's a primary cutaneous ALCL, it tends to behave almost like LYP, right? So primary cutaneous ALCL often behaves like LYP, and you treat it like LYP. It's not likely to respond to narrowband, but low-dose methotrexate often does just fine. And what you don't want to do is aggressive treatment that just becomes more and more aggressive regimen every time it relapses, which is going to be its spontaneous course, regression and relapse. Okay, well done. Let's see what else we need to get here. Okay, so you're signing out, and it comes in rule out squame. What are you thinking?
It does look kind of squamous.
Yeah, it looks like a squame. And now you look down in, and that was exactly the history here. Looks like a squame. And now you look down in your dermis. What's going on in your dermis?
It's like a myeloid.
Looks myeloid, right?
Yeah. Wow.
You have EOs, and you have primitive myeloid cells. So what are you thinking?
I'm thinking leukemia.
Exactly.
Myeloid leukemia.
So by the time I left New York, now we had a big volume in New York. We were 150,000 specimens a year. But we had 4 cases, 1 a year, where it came in as an AK or a basal or a squame, and there was leukemia cutis, myeloid leukemia cutis underneath in the infiltrate. And so, those twofers occur, and, of the 2, the squame's important. But, so, you want to look at everything on the slide to include that little perivascular lymphoid infiltrate, because sometimes it ain't lymphoid, right? And in this case, it's big and hyperchromatic, and you have immature EOs, and you have immature myeloid cells. And so what stains could you do to show that it's a myeloid infiltrate?
IPO.
So myeloperoxidase, lysozyme, leader, any of those would work. Okay. Okay, so something that looks like a keratoacanthoma, and then you've got an infiltrator on the Ka that's a little bit denser and a little bit grayer than what you'd expect, right? Looks kind of Merkel-y. And Merkels disproportionately occur with squamous neoplasm. So Merkel with Bowen's, Merkel with squame, that's like 40 times chance and chance alone. So you definitely see it. And then the question has always been, how about Merkel with basal cell? Do they just get missed because they're both so blue? You would think with the metastasis that you might, might catch on at some point, but Merkel with squamous things, not uncommon. And see how these things sort of make chains with a little bit of nuclear molding? They break up into little chains. That's a clue to some of, especially lymphoid leukemias, like lymphoblastic leukemias do that. So leukemias you can see at different ages. Myeloid leukemias are often adults. Lymphoblastic lymphomas and leukemias are often kiddos. There's one coming in, a Cutis image quiz that's going to be published in a couple of months that is, absolutely typical. It's a little kid with a mass on the scalp, and you biopsy it and you got an infiltrate that looks like that. It's probably not just going to be lymphoma in the skin. It's probably leukemia lymphoma in that kid, and they certainly need referral and they need appropriate treatment. And, you will see them. And kind of scalp of a kid is common. Okay.
This is a pretty diffuse population of somewhat pale cells.
Yeah.
Lots of cytoplasm, pretty close to the skin, so a little more top-heavy. I'd be leaning towards something T-cell initially, but I want to look down at the cells and get some basic stains, of course.
Okay, so the world is your oyster. What stains do you want?
CD3, CD20.
Okay, there are a few CD20 cells, not much, and CD3, sort of the little black cells at the periphery are CD3 positive, but those big pale cells, they're not.
CD30.
Negative. No history of rituximab.
So CD5 wouldn't really make sense because they don't look like mammal cell.
Good for you. Can you imagine yourself having said that 12 months ago?
Looks like you
Probably
learned
not.
something.
Probably not. I mean, that's good. That's good. Where one of my pet peeves is you send a case off to a heme path person who orders every B and every T cell marker known to man. That's not appropriate. I mean, cost-effective medicine is what does it look like? What do you really need to come to a diagnosis? So well done. It is tempting, but go ahead. Fight that temptation.
How about we can get myeloperoxidase?
So myeloperoxidase picks up a few myeloid cells, not much of the infiltrate.
What about like an S100 or even a keratin? I want to know what those big cells are.
So exactly. So nothing's making sense. So now you cast a wider net. S100 negative, keratin strongly positive in those big cells. What are you looking at? Lymphoepithelioma like carcinoma because it mimics lymphoid follicles, right? So lymphoepithelioma like carcinoma looks like the nasopharyngeal lymphoepitheliomas, which are basically a squamous cell, a poorly differentiated squame with lymphs around it mimicking lymphoma. So that's exactly what that is. And, that's basically how you normally back into the diagnosis. When nothing's making sense, then you cast a wider net.
So this one's kind of diffuse top and bottom.
Okay.
There's a whole bunch of them lining up at the DEJ, and
Yep.
a good amount of epidermotropism, so I'm worried that this is MF.
Yep. So this is a T pattern. So your epidermotropic, the big nasties, you know, look at all of those lymphs in the epidermis and look how little spongiosis there is in comparison to the number of lymphs. So way too many lymphs for too little spongiosis. You've got a little papillodermal fibrosis creating a little grindstone there. You've got a lot of basilar tagging. You know, looking at the infiltrate, I think it's so dense it's hard to make out a bare underbelly or anything. And a lot of the big nasties seem to be in the dermis as well. So is this a patch MF?
No, this is more like
Advanced
Plaque or
plaque
tumor.
going on to tumor. Exactly. It hasn't lost its epidermotropism yet, but it's, you know, a lot of the nasties are down in the dermis, not just up in the epidermis.
If you saw that, Dr. Elston, what stains would you get even if you were pretty confident?
So if I saw that, you know, it depends on the patient's history. If this is a person with big plaques, you know, greater than 5 centimeter plaques and a limb girdle distribution and nodules, I'm probably going to call it MF. They don't look like transformed. I'm not going to get a CD30. I probably would just call it on H&E with just a comment, because every MF patient probably needs the comment that you look at drugs. Because drug-induced pseudolymphoma can look just like MF and can be clonal, and basically is best thought of as drug-induced T-cell lymphoma, because it's going to progress if you stay on the drug. And if you come off the drug, it'll go away. So, you know, every MF patient, you ought to look at drugs.
Well, certainly hard to follow the last description, but we have a grin zone here.
Okay.
Larger cells.
And tell me about the cells. First off, cytoplasm, no cytoplasm.
It looks like lots of cytoplasm.
Yeah, cytoplasm. You got it right, even though it wasn't the second choice. Good for you. And nuclear molding, no nuclear molding.
Yeah, there's nuclear molding.
And line up in single files.
They do.
So they have cytoplasm, they line up in single files, they have nuclear molding, they have mitotic figures. What kind of things are you thinking?
You said like a leukemia.
Yeah, absolutely. This looks like a leukemia. So, you know, how are you going to stain it? Well, it depends what it looks like and what stains you need to answer your question. So this one, I'd go right for myeloid stains and then go right for a marrow. I probably wouldn't spend a whole lot of money on other markers for this patient who's looking at lots of medical bills down the road.
Why is that one not like a blastic plasmacytoid? It looks kind
Well,
of plasmacytoid. Some of them.
Okay, so blastic plasmacytoid dendritic is leukemia. I mean, it's basically a primary myeloid leukemia of skin.
But a lot of those, you look at them and that's your first thought on them. What is it?
Oh, I see. Okay, so they tend to have less cytoplasm than this, and they're darker. The cells really tend to be, they're not jet black, but they're dark, ominous gray, like thunderstorm clouds gray. And then you're often wondering lymphoid for those, whereas this, you look at it, it looks more myeloid leukemia. Those, they're bigger, they're darker, you're wondering about lymphoma, but they're CD4 positive, but CD3 negative. And then that takes you to blastic plasmacytoid dendritic. This one looks more like a myeloid leukemia. And, you know, people really haven't looked enough to see how many of these might express CD123. My guess is some of them do, because, you know, the more we know about them, there's really not that much difference between primary cutaneous blastic plasmacytoid dendritic and a primary bone marrow myeloid leukemia other than where it started. You know, they're both nasty leukemias. The blastic one is more blastic. So, you know, they tend to be larger, rounder.
Because they call it, you know, in the name plasmacytoids, but I don't know what that meant.
Yeah, I know. To me, I've yet to see one that really looks plasmacytoid to me. I think it's because the normal plasmacytoid dendritic cells are CD123 positive. I think that's why it carries that name, not because it looks on H&E plasmacytoid, which is confusing.
So a lot of papillodermal edema.
Lots of papillodermal edema.
Lots of atypical appearing cells in the
Yeah.
superficial dermis.
Yeah,
particularly.
so what's in the epidermis? Neutrophils, there's some crusting, a few lymphs, but they look normal. The nasties are here, right? And are the nasties big sheets or a little collection?
I mean, there's a diffuse infiltrate, but it looks like little collections of nasty cells.
Yeah, kind of like right there. So is this going to be clinically a tumor, a plaque, a papule?
It's going to be probably a focal area, so probably like a papule.
Yeah,
raised.
probably like a papule. And will the papule have epidermal change or no epidermal change?
No.
Well, it's got a crust, it's got
a
scale.
crust,
It's got a crust, it's got scale. So this will be a papule with epidermal change with ugly cells. You starting to picture this patient? You want to know, is this a solitary papule or are there lots of papules? Well, this patient has lots of papules, and they come and go,
Oh, lucky.
and they kind of crust, and yeah, exactly. So, like a lymphomatoid papulosis. Okay, I think we've exhausted time. Are there questions that anyone has on these things? Okay, let's
You never hear it.